give his talk. Dr. Satyanarayana Mysore is an MBBS, DNB, FRSCP Australia, FSCP, FCCP, FRCP UK, GMP ISB. He is Chairman and HOD and Consultant Department of Pulmonary Medicine, Manipal Hospital. With this brief introduction, I am requesting Satyanarayana Mysore sir to give his talk. Thank you, sir.
Thank you, sir, for those kind words. Yesterday, while I was excited to come to Vijayawada. This is my first trip. So I was told that this place was known as Bezwada till such time Uday and Lokesh came and set up an excellent pulmonology unit. After that, this is known as Vijayawada. Pathway the talk will go through. So we all know that there was extrinsic allergic alveolitis. That was the old word hypersensitivity pneumonitis, and that is like an old wine rebranded. But the understanding of this disease pathology, radiology, clinical course, and how do you divide it into two distinct forms. So previous classification of hypersensitivity, basically it is an interstitial lung disease, unique in the sense there is dual mode of inflammation. The Gell and Coombe classification, if you look at, there is type 3 hypersensitivity and also a coexisting type 4 delayed hypersensitivity. Two pathophysiologic mechanisms coming in. When we look at lung zones based on West pathophysiology, you have areas of high ventilation, low perfusion. You have areas of high perfusion and low ventilation, which is apex to the base. The disease follows exact physiological pattern. Wherever the ventilation is more, those are the areas that you will see the radiological features. So earlier classification was based on time, but now they have been grouped, but not on the basis of time, on the basis of inflammation versus fibrosis. If the fibrosis score is more, it becomes fibrotic HP. If it is less fibrosis and more of cellular inflammation, which is seen as GGO, which we will discuss later, then it will be non-fibrotic HP. Radiologically, very simple to remember that the opacities are kind of distributed more in the apex and some clearance in the clear areas in the base. So maybe easier to remember, 1 in 2 lakh population can develop hypersensitivity, that is the frequency. There is a mind-boggling amount of antigens identified which causes hypersensitivity pneumonitis. And these includes everyday products like what we use as malt, to sugarcane, to cotton, to paint, to potting mixture as hobby, wood carving, so many entities. And there is a immunological correlation that we may all be exposed, but only few may develop the disease. In central part of India, like Mumbai, we see more of pigeon-related hypersensitive pneumonitis. Earlier criteria was that pigeons in the vicinity would not matter. You should have a pigeon, caged pigeon, cleaning of the cage, and that is where the particulate gets aerolized into the lung. But times are changing. Pigeon density is more in apartment complexes, and there is cloistered and less circulation of air. So there is a complex interplay between the host, the genetic factors and the environmental agent. That may explain why some get it and some who are exposed may not even get those symptoms. Caution is that people who are smokers, you may see a significantly less number of hypersensitivity because the cellularity in the ball changes. So the type 3 is negated in these patients, but if they do develop hypersensitivity, directly goes on to fibrotic variety, and irrespective of high HP, the smoking has its own perils. UIP is going to hit them at least 10 years later. So the pathophysiology is inflammation caused by this antigen, which leads to both type of hypersensitive reactions, and that triggers immune complex reaction. So once there is an immune complex, it is like having because of the type 3, it is almost like having a serum sickness. There will be cough, there will be feeling of unwell, hacking, irritating cough, and fever of few days duration, dyspnea, which can happen and mimic any of the respiratory infections. And along with this, when you evaluate, you will have serum antigen. That is, if there is a pre-test probability suspecting hypersensitive pneumonitis, even before you order an investigation, then these values these results have more significant values. So if there is the symptoms are not evaluated, or either patient doesn't come or we miss, then it leads to frank delayed hypersensitivity. T cell mechanisms take over from the B cell, which is type 3, and you have increased CD8 cytotoxic cells, resulting in chemokine. And in any part of the body, if there is engulfment of a particular substance by dendritic cell, initial presentation is after covalent binding by CD28 and B52, you have signaling to the TH lymphocyte, TH1, and you have co-stimulation antibodies coming into picture. But in hypersensitivity, there is both stimulation of B cell, there is activated B cell, immunoglobulins are formed, and that is how we see immune complex formation on one side, and on the other side we see activated T cells. Onset varied, and when I project about the diagnosis, I cannot overemphasize on the history. Professional history, to hobbies, to any artistic persuasions that individual has, to smoking, anything and everything obtained in the history will help you. So there will be inspiratory crackles, and sometimes the disease tends to be very insidious. So 3 important points for a diagnosis. One is identification of the antigen, which is basically number 1 history, and that will set your pre-test probability. Then you look at radiological findings of HP, which we will dwell into. And third is finding Ball lymphocytosis. And when I say Ball lymphocytosis, again number of differential diagnoses are thrown in. How do you differentiate or distinguish that from sarcoid and other inflammatory conditions? So initial thing is to, of course, document typical patterns of interstitial pattern on the chest imaging, which is high resolution CT. The ALAT, which is the Latino Chest Foundation, Japanese Chest, Thoracic Society of Australasia and American came together and put a consensus guideline, and proud to say that Dr. Ganesh Raghu, our Indian man, is one of the prime persons in the panel, and they came out after looking at nearly 700 studies. Most of the studies had confirmation bias, inclusion bias, and after all that they came out with expert consensus practice guidelines, which even mandates how should a high resolution CT be done. The method of acquisition of imaging is very, very important. Guidelines may suggest that there may not be a huge role based on evidence for prone and supine, but we always ask, any HRCT is worth its salt if you do prone and supine. And then once you have identified that you have got a good history, you may end up doing BAL. I'll come to the relevance of histology and other things later. So once that is done, you can subject it to multi-D discussion. Most hospitals in Manipal, at least, we have multi-D clinics set up, and it is little tedious because like-minded pathologists, radiologists, clinician, everybody has to find particular dedicated time. So we make use of postgraduate teaching session to get MDT together to discuss in Manipal Hospital, Bengaluru. So then question of sampling, tissue sampling will come up at that point of time. So once we look at radiology, basically I would always remember that there is an eminent radiologist in the audience. I'm sure he will correct me. So I look at the GGOs as if it is the ECG trace paper, 1 millivolt, and each 5 squares are separated by longer square. But what if the lines were squashed? You would see a solid image. There is no concealment of pulmonary vasculature. There is just coming together of the diaphragm as we see, and that can create GGO. If I have normal lung, I breathe out and do a CT scan, I will develop lot of GGOs, which are basically artifact. So when you are looking at a CT, first look at the posterior aspect of the trachea, make sure it is not indented anteriorly, it's fully distended, which means it's a good inspiratory view. After that, acquisition is done, and then you do a prone as well. So typical HP, you find that upper and mid zones are involved, as I said, zones of good ventilation. There is patchy GGOs, and these will follow any GGO. We need to look at two things. Are they angiocentric? Are they following blood vessel? Are they following the airway tubes? Bronchocentric. So we look whether they are bronchocentric, and if portion of the lung forms GGO, it will lead to air trapping, and that is what we look as a mosaic attenuation. And there may be nodules, centrilobular nodules. And second variety is compatible, when there is GGO but some cyst thrown here, there, and the distribution could be not bronchocentric but angiocentric. Even then, HP is not rolled out, and that's why we say maybe compatible or probable HP. So these images make it very clear. In the first one, we are seeing areas where we expect air is much denser, lower density of air, it would appear black. However, you find that because of the trapping, areas of the lung are squashed, inflammation leads to GGO formation and concealment of the non-concealment of the pulmonary vasculature. So we have looked at this, and earlier it was called as cheese head sign. I think the Western world was obsessed after naming most of the signs after food products. They got bored and said, let's enjoy the food, so let us name it as 3 density sign on radiology. That is evidence of GGO, mosaic attenuation, and normal appearing parenchyma, especially towards the bases, suggestive of this. So this is why I said history, and history is very, very important. When we look at the diagnostic algorithm and we bundle it with BAL, with tissue sampling, without tissue sampling, and on the left you look at typical probable HP. If you have a good exposure history and you test for serology may be positive only up to 40 to 60. Negative IgG testing doesn't rule out HP. That is one thing we have to remember. But bingo, if you get a HP panel, which is only a very select panel, and therefore history becomes important there. Then you are landing in the zone of moderate confidence, and if there is lymphocytosis, typical image, then you are probably not going to subject the patient to tissue sampling. So there may not be marked eosinophilia, because once eosinophilia comes in diagnosis, your differentials will increase, and lymphocytosis is hallmark. They have divided into 3 different groups, and so 30 to 70%, and it distinguishes if there is a fibrotic HB, almost a DD of UIP, presence of huge amount of lymphocytosis in BAL is a distinguishing feature. Serum precipitants, which are basically IgG antibodies, and however if they are negative, they don't rule out. If they are positive, they don't kind of make it as an absolute positive predictive value. It doesn't confirm the diagnosis. So the whole picture needs to be looked at. Lung function, if the amount of fibrotic score is more, you get a restrictive pattern. If mosaic pattern is more, you may still get a mixed or an obstructive pattern. And important that diffusion limitation will also, I thought I will stick to the time. So if there is DLCO should be done in all these patients, because at some stage if there is a rapid progression, then we will be looking at lung transplant. Prognostication is quite good with not just with the FEC, DLCO as well. At my place in Airport Road, Old Airport Road, Manipal, we have CPET, and we do a full cardiopulmonary exercise testing when feasible. So this is just an expert consensus statement, and with lot of maturity one will realize that lung biopsies are not indicated unless we think we don't have a provisional working diagnosis. And it may not, before we subject to tissue sampling, we need to consider whether this is going to change the entire outcome. Are we treating something as IPF, UIP pattern, and are we missing out HP? But then when we look back, if the thing is gone in a particular order and algorithm as we discussed, maybe not to subject to biopsy. Transbronchial lung biopsy is almost a no-no. However, if it is a non-fibrotic, when there is a lot of inflammation, it may have role. Cryo definitely helps. SLB, surgical lung biopsy, also helps. We have a very good cardiothoracic team. Any surgical lung biopsy is only 24-hour stay. They do a VAT and take a part of the lingula and get the patient home next day. So if biopsy is done, 2 characteristic things to be looked at: chronic interstitial changes and poorly formed granulomas. These are important things to look for in the pathology. Now, a diagnosis of probable non-fibrotic can be based upon the same typical non-fibrotic in the absence of acute non-necrotizing granulomas. Then histologic evidence of NSIP type of picture, organizing pneumonias, peribronchial metaplasia, all these things come into picture, and biopsy therefore in a non-diagnostic or when there is lot of dilemma, it definitely helps. So management, I am sure we all know, we are trying to suppress both arms of the immunity. Before that, avoidance is important. And generally, you give 4 to 6 weeks of immunosuppressive steroids. You can use MMF and other things. Rituximab has been used. Antifibrotic is not precisely evidence based. Only 700 patients out of the inbuilt and Panther trial were looked, and 173 patients out of that showed 52% FVC preservation, DLCO preservation at the end of 52 weeks of trial. So there is no harm in adding it on if the fibrosis score is more, but if there is more of cellular inflammation, I think the first thing is avoidance, education, keeping it as a patient journey. And just to close my talk, this is a lady, elderly lady who had immunotherapy and developed a pattern of hypersensitivity pneumonitis. Only the bases were spared, and we stopped the offending agent, gave steroid, and in 5 days she was able to head home on minimal supports. So thank you for this opportunity. Any questions? Happy to take.
Thank you, sir. We'll take the questions later. So in the panel discussion.